So I think it is 1 o'clock, so we'll start our NASCI Curious Cases webinar. So my name is Dhiraj. I am one of the cardiothoracic radiologists at the Medical University of South Carolina. Uh, if you are new to this platform, so we are doing this webinar, trying to make it more interactive. We'll be showing some cases, we'll discuss and try to come up with some diagnosis. Today, my colleague, Dr. Kavakas, will be presenting a few cases, and then if time permits, I will also present a few. So Dr. Kavakas, please go ahead.
Well, thank you so much for giving me the opportunity, Dr. Barua. I'm going to share a few cases from our practice, and I'll be very happy if it can be interactive. And let me get started. The first case. So this is a 72-year-old man with chest pain, and we are looking at the MRI. And what's the most likely diagnosis? Anybody wants to join and make comment about this first case?
So, infarct?
Yes, awesome. Yes, of course. Thank you so much for contributing. This is this is. I just wanted to start with this relatively easy case. As we know, this is infarct, and I want to show you the extent of it. And I want to give you a little bit history about this case. This case had an acute MI, and they know it. And this is a fourth day after the MI, and they want us to do a viability study to, they were trying to decide if they are going to go with CABG or PCI. So we did this MRI study. The good thing is you don't have acute or subacute MRI patients many times. Most of the time we see the chronic findings. This is subacute MI, and I want to discuss further findings in this MRI. If you look at this delayed enhancement picture, as you can see, this belongs to the territory of a vascular territory. That's the first thing. And the second thing is the extent of the delayed hyperenhancement. The delayed hyperenhancement, if you look at it, it's involving almost the full wall thickness. Not only that, so we have this hypointense area here. We will come to that later on. But that's also an additional finding here. If you look at it, if you want to say this is an RCA territory or a PDA territory, this is perfectly fits to that area. And then I guess this one was the SSFP. I wanted to show you this. This is a beautiful sequence showing you, since it has the T2 weighting, and this is acute / subacute MI. This is fourth day of the MI of this patient. You can nicely see the edema here. And it's so interesting because most of the time when you have this patient on chronic MI, you're not going to see the edema. You will see a thinning and hypointensity. So that was beautiful. I didn't see many cases like that. As I said, we're not getting the acute MI, subacute MI patients on MRI most of the time. This was just one case. And then we will continue. I want to discuss about the, whenever we see delayed enhancement, it's always like when it is infarct, it's easy. When it's non-ischemic type delayed enhancement, usually you need to dig the history a bit. So I usually tell our resident or fellows, say, hey, whenever you see it, if it is infarct, yes, it's straightforward. If it is not infarct, just go to the history, see what's going on with the patient. What are they concerned? And then the second thing, look at LG pattern. As I said, is it ischemic? If it starts from the subendocardial area, is it non-ischemic, meaning more mid-epicardial predominantly or subepicardial area? And the other important feature is if you're doing T2 mapping or even SSFP, sometimes may give you a signal. You may be able to differentiate fibrosis from edema, because fibrosis is not gonna have a high T2 signal. On the other hand, edema will have, as in our case. The other thing is wall thickness. So I'm gonna get to that in a second too. Wall thickness is important because that will also give you some differential diagnosis, which I'm gonna discuss in the next slide. And wall motion abnormality. Is there any wall motion abnormality, hypokinesis, or is it normal looking myocardium? That may help you, again, like differentiate maybe ischemic type events or maybe myocarditis. The additional findings are, I'm talking about anything that can help us, such as, let's say we are looking at a case and they're asking about a non-ischemic type delayed enhancement. And you look at the mediastinum, you see all this lymphadenopathy, you know that maybe the patient has sarcoidosis. That may help. Or if you have a pericardial enhancement or pericarditis, you may suspect there might be also myocarditis. So those additional findings might be important too. So when we when we look at the enhancement type, we can just divide it to ischemic versus non-ischemic. Of course, we know that the ischemic type usually start with subendocardium, and depending on the degree of the ischemia or infarct, it will just start from subendocardium and involve the whole thickness. So the other thing is non-ischemic type delayed enhancement. I'm going to get to that. There's a very good article I'll discuss in a second. In this dilated cardiomyopathy, if you look at it, it's not just delayed enhancement. When you're looking at the myocardium thinned and it's dilated, and you may be able to see basal interventricular mid-myocardial enhancement. The other thing is you're looking at another heart here. As you can see, the myocardium is really thick. When you think about that, you have to combine all these findings to put the diagnosis for non-ischemic cardiomyopathies. For this hypertrophic cardiomyopathy, usually there will be demand ischemia in predominant in mid-myocardium, and then LV non-compaction. At least my limited experience, I didn't see many delayed enhancement, but they say at the area of non-compaction, you may be able to see non-ischemic type mid-myocardial delayed enhancement. Cardiac sarcoidosis, as you may know, it's usually they say basal inferior lateral wall will be the most affected area. But as I said, you have to combine all the findings. You need to look at the mediastinum, if possible. If the patient had chest CT, you may look at if there's any signs of sarcoidosis, a cardiac amyloidosis. As you can see in this image too, sometimes people use the reversed nulling, meaning the myocardium will go dark, and then myocardium will go dark earlier than blood flow. So you can use that. And sometimes it's patchy and diffuse. Sometimes it's just diffuse subendocardium, not limited to the LV myocardium, but also involving the RV myocardium, even the atria. So let's move on to the next one. And here I want to just briefly talk about wall thickness may help us just narrowing the differential diagnosis. Why? If there's thinning and there's associated hypokinesis, you may say this is probably chronic infarct, even just looking at SSFP. And again, dilated cardiomyopathy, usually the myocardium is stretched and the LV is dilated. So again, like wall thickness is something also you can use to narrow the differential diagnosis. Most of the infiltrative phases or hypertrophic cardiomyopathy will result in thickening of the myocardium, and that will help too. All right. I hope I'm not going fast. Okay. So this case, again, like we are looking at the perfusion of that case. I know the contrast is not great, but as you can see, this is the perfusion image. This is not stress perfusion, this is rest perfusion, but you can see like at least the RCA territory, there's almost no filling. Even if you go further, so this area is completely infarcted. And this is the functional imaging showing the area. You can see that there are lots of things going on in this image. It's not just the hypokinesia of the inferior wall, but also you can see the intraventricular dysynchrony. What happens is when the patient had MI, acute or subacute, or even chronic phase, when there's fibrosis, you may start seeing re-entry that will cause the arrhythmia in those patients. All right, let's move on to the next one. Okay, so which vascular territory is most likely affected? I guess we already talked about it. So this is RCA territory. I don't know if you use RCA territory. I know 85% of the time this will be RCA, but probably 15% or 10 or 15% of the time this will be just circumflex territory, depending on the dominance. It's probably safe to say PDA territory. I guess so. I don't know if somebody wants to make a comment about here. We usually try to say RCA, but we never know if the dominance most of the cases. So that's one thing to keep in mind. I try to use PDA territory for those areas. So of course, there will be LAD territory, including the 2/3 of the anterior septum and anterior wall. And lateral wall, you usually will, this again, depending on LAD and circumflex dominance, but lateral wall, you will be usually circumflex territory. So I just wanted to give you this diagram. It shows you 17 segments of the American Heart Association segments and shows you which vessel supplies which area. All right, next one. So, LG, what does hypointense area within the infarct zone represent?
This is
NBO.
just interesting cases. Yeah. MVO?
Yes, thank you so much for answering. Yes, this is MUO. The question will come from the resident say, why is it not thrombus? Why is it not thrombus? It looks like a thrombus here. Anybody has an answer? How can we differentiate MUO from thrombus?
By early gadolinium enhancement sequence?
Yeah, but they will both look dark on this. So how can you differentiate thrombus from an MVO?
Yeah, so I
Any
have to be
enhancement?
limiting the myocardial thickness in CINI image to the late enhancement. So thrombus, it is intracavitary thing, but MVO is something in the myocardium itself.
Awesome. Thank you so much. So yes, uh, especially in this case, we know that. I will just try to draw something. So especially for this case, we know that there is no myocardial thinning yet. This is acute slash subacute MI. If you follow the endocardial contours like this, right, and you know that the endocardium is likely here. So as you, as just Mahmoud said, so this area is within the myocardium, not in the intracavitary. Yes, there might be, there might be cases like you will have some difficulty to decide, especially, and you just need to keep in mind, usually, if anybody wants to make further comment about it, usually you have to see from its definition, MVO should be acute versus subacute, although I don't understand some chronic cases, like very rare cases, I saw that too. So that might be difficult to differentiate from thrombus at that time. But as long as you know that you can appreciate the endocardial contour, you may, if you can say that the hypointensity is within the wall, you may be able to put the diagnosis. In this case, there will be other thing. If you look at SSFP, I need to go back here. Please take a look at the SSFP here in this case. Maybe I will show you the functional imaging, this one. So please look at SSFP. See, you can see the endocardium, you can see the blood pool, and there's nothing within the endocardium. And you can see even this infarcted area, MVO, even relatively looks like myocardium here. So you can use SSFP to help you also. As I said, the most important thing to decide where's the endocardium. Anyway, thank you so much for helping me with that. And then let's move on to the next one. So, and we have this LGE, and of course the main question is it viable? And what's the answer?
Non-viable?
Perfect. So the answer is it's definitely non-viable for RCA territory, but the question should be, what do you mean from viability? Are you asking about the RCA territory? Yes, RCA territory, if you look at the delayed enhancement, it involves a full thickness. And then it's most likely non-viable. Whatever you do here to RCA territory is probably you're not going to be able to help the patient. But if they are asking about the rest of the myocardium, in this case, they were honestly asking for the rest of the myocardium, then LAD and circumflex territory most likely looks viable. I couldn't see any other LGE. And it's tricky to decide viability and non-viability. That's why I want to discuss this briefly here. When we're talking about viability, when we are reporting it, how do you report it? Like, do you say LAD territory is viable, LCX territories, or do you go by segments, like define all the segments separately? The other thing to keep in mind, when we are talking about even the segments, we need to keep in mind, so we cannot just look one image and decide. Let's say I'm looking at this image, and in this image, this LG is involved in the full thickness of the myocardium, correct? Yes, it's almost 100%. But I cannot just decide just looking at the one image, because if we are talking about the full RCA territory, the RCA territory almost start from the base, go to the apex. So we need to, what we are doing in our practice, we are looking at the average. You may say that, are you doing some calculation? Unfortunately, we are not doing calculation. We try that too. We are not doing quantitatively. We are qualitatively looking at what's the average involvement of the myocardium at that area. We usually try to go with vascular territory. As I said, maybe there are some of you guys mention it by segments. I'm curious if anybody use any other method to report this. Sometimes I find it really difficult to report.
No, I agree with that. It can be difficult depending on your surgeon. So I think you wind up tailoring it to whatever they need.
Yes, I think so too. Sometimes you have multifocal infarcted areas. Then I don't know. It's in this case, I did the report. It was easy. I said RCA territory non-viable. The rest of the myocardium was viable. But there are sometimes multifocal areas. Then it's just I am trying my best to again like summarize it according to vascular territory and give them the average. And I believe they even use the functional data. They're even using some of the nuclear medicine studies to look at perfusion. And it has to be. I think we're not in it, our institute. But I think it should be like the surgeon, cardiologist, and radiologist should sit together and decide, because these are important things, because this is pre-CABG evaluation, and CABG is not. It's a fairly invasive surgery. And I guess this was the last question for this case. Yes, I'll talk about another article. But for this case unfortunately couldn't make it. So unfortunately, the patient was very unstable. They tried their best, and just because of infarct-related VTEC and ventricular fibrillation, the patient unfortunately passed away. And the next one, I want to just briefly, because this is a major discussion in our department. So this basal interventricular mid-myocardial stripe, we see it, and we even see it even like normal cases. Like when I say normal cases, let's say the patient has a cardiac mass, a myxoma, we still see it. So some people, like, there are lots of publications out there saying it's significant, not insignificant. But I find this article very funny. They are showing that some of them actually belong to septal perforators, because I'm hesitant to call this a mid-myocardial stripe for all cases unless it's really must or relevant. Let's say the patient has dilated cardiomyopathy, then I can, but I have to be very convinced that it is real. So I don't know what's your experience with this basal interventricular mid-myocardial stripe. Do you call them all whenever you see it, or it just depends on the clinical indication?
So just a small comment regarding the previous patient in terms of detection of viability or non-viability. I just like joined a little bit late. So if it's acute setting, if the patient came in acute MI, I think it's hard to say this is viable or non-viable, because all this late enhancement could be just related to edema, and all the things will go away, all this late enhancement, once the edema or subside. So I think we cannot say viable. We couldn't we cannot be able to say viable or non-viable in acute setting. Is that
I
correct?
definitely agree with you. They usually don't ask it in acute settings. Usually, I definitely agree. That's why in my report you cannot really assess it in acute, subacute, because you don't know how much of it will be reversible, as you just said. The reason that I concluded it most likely will be non-viable just because of the degree of MBO. So these microvascular obstructions areas probably will be very irreversible, not the delayed enhancement itself. But still, I'm feeling like you can have some edema, and I agree with you. There will be some irreversibility of it, but probably this whole area will be infarcted in long term, and the extent of the infarct is really extensive. I totally agree with you, and I in my report I put that whatever you said. I agree with you. That was going to be actually I was going to ask you, can we do the assessment from MRI on acute settings? Is it fair to say it? Can we
No.
demonstrate this here? Yeah, I agree.
Yeah. I'm a cardiologist, not radiologist. So I'm talking about from cardiology perspective. In acute setting, we don't need to do like MRI. So if it's straightforward MRI, we can go. Except if like the patient didn't come in like and just we do like chest pain, troponin positive, and do angiogram, and it is normal angiogram. So we are thinking about like Minuka subtypes. So this is the next step, to do MRI to confirm is it myocardial infarction or myocarditis or Takotsubo or other things. I mean, like in under Minuka subtypes.
Thank you so much. That's what actually was also my question to cardiology too, and thank you for answering. Any other contribution before we move on?
Yes. I just want to ask about the same thing that Dr. Mahmoud asked about. To the best of my knowledge, that MVO occurs in acute ischemic state, acute infarct, and I think we judge if the myocardium is viable or not after 28 days. It's just for my knowledge. Can we judge viability in acute state?
So you are evaluating the
Or predict if the myocardium will be viable or not regarding the extension of infarct size and presence of MVO?
yes, thank you so much. So you don't look at the myocardium immediately. That's what I was thinking. And thank you so much for contribution. Any other contribution before we move on? Dr. Mahmoud?
Yes, sorry. Uh, Can you repeat the question again? Sorry.
Is there any other contribution?
No, that's okay. That's fine.
All right, thank you so much. So let's move on to this. Okay, before we move on to the next case, can you also share your experience with this interventricular, basal interventricular mid-myocardial enhancement? For, let's say this is an incidental finding. Do you call it every time, each time? Or do you correlate it with SSFP findings if there is? Because
Yeah. Yeah, usually in my practice, I correlate with the cine image because I find this is non-specific, especially except or this like dilated cardiomyopathy type, non-ischemic type. But usually I find two things can explain this mid wall. So maybe like septal branch of the coronary, this is one, and second maybe like RV trabeculation. So I would be like a very cautious to say this is real late enhancement except of like go like to see the cine image, and I'm sure this is like not septal coronary or this is not trabeculation in the right trabeculation in the right ventricle, and then I can see like two orthogonal planes like short axis and long axis late enhancement, and if I see that's a late enhancement in two orthogonal plane, I have to report. Yeah.
very good. Thank you so much. Anybody else? All right, let's move on to the next case. Okay, so 67-year-old woman with bacteremia. What's the most likely diagnosis? I'm gonna scroll the image for you. The patient has some sepsis or bacteremia, and we have this CT. I'll go slowly. All right. Anybody have any answer? I can give you a little bit more clinical information. I'm holding some of it. The patient has some immune deficiency. That's the one thing. The other thing is actually the patient had also Leopold's abscess. Anybody wants to answer now? Or
Sorry, what did you say about the abscess that he had?
had
Where?
Leopold's abscess, and they drained it.
Okay, because those features looks aggressive and looks like infection process.
Yes, awesome. Thank you so much. I was when I saw the case, we had also an outside study, and so I know that they were asking about abscess, and I know this is going to be abscess. Also, like I was very surprised with how aggressive it is, especially the circumflex. If you look at it, that circumflex pseudoaneurysm, I personally didn't see it before the infection eating through. You know, we saw all sorts of endocarditis, perivalvular abscess. This looks like perivalvular abscess normally, the look of it, like you can see the wall enhancement. It is just aggressive. It is even like trying to go or compress the coronary sinus, causing some thrombus over there. So to me, it was interesting. And if you look at it, I don't know when it happened because we didn't have other prior. The outside study was also very recent to this study. If you look at the lateral wall of the left ventricle, you can see even like see the hypodensity. And so this patient had some sort of, I don't know, age indeterminate lateral wall infarct too. I don't know if it is because of this infection or it was there. That's I cannot answer. But it was surprising. So I did a little bit digging of this pseudoaneurysm thing. I just saw a couple of case reports, infection causing this kind of coronary pseudoaneurysm. Anyway, this was an abscess. I want to, or maybe I want to ask your opinion. Did you see that aggressive abscess causing the pseudoaneurysm in your practice before?
I saw before like very aggressive infection, but causing some infarction of a small territory of the left circumflex, and then pseudoaneurysm of that infarcted region, but not that pseudoaneurysm of the coronary artery itself.
Yes.
That's a wonderful case.
Another thinking, like, because if I didn't have the outside image, this circumflex pseudoaneurysm wasn't there. It wasn't there. So this happened because of the abscess. Because another consideration, sometimes I guess our cardiologist friends can help us with that. What I read from the literatures, they are saying that after the invasive, catheter angiogram, you may create pseudoaneurysm that may get infected. But we know that in this case, pseudoaneurysm happened later on. Dr. Mahmoud, do you want to say anything?
Just small comment. I mean, I can go just one step back. So why CT, not MR, be requested for the patient?
Well, they knew that this is an abscess. They wanted to see the extent of it and compare with the outside imaging. They weren't trying to give differential diagnosis if this is an angiosarcoma or that wasn't the question for the clinical team. That's why they ordered CT. Probably MRI would be superior to characterization of this. But as I said, the clinical team wasn't. They were sure about their diagnosis of the abscess. They were just asking us the extent of it. And in this case, it was helpful to see also the extent of it. I have another case I want to discuss with you. Sometimes I feel like, CT gives you that higher resolution. Sometimes it's superior to MRI, especially if you know the diagnosis. If you don't need the tissue characterization, that may be better instead of doing an MRI in this case.
Yeah, okay, that's right.
Okay, let's move on. The next one. All right. In this case, also, we saw this erosive change in this was, again, I guess, T9 or T10. So you can see the erosive change. You can even see erosive change here. So this patient also had osteomyelitis. They didn't know about that. So it's important to just pay attention to other things because this is not even like mentioned in the prelim report. They were just probably thinking like some degenerative change, but not in this case. In this case, it was important because this turned out to be osteomyelitis. All right, we talk about that. Okay, so I think this is interesting. I hope you will find this interesting. I know the finding is very subtle. This is the finding. That's why I wanted to point out this patient had recent history of pulmonary denervation. What's the most likely diagnosis? This little thing is what we are trying to understand. Anybody has any opinion? Any answer is okay. Because I didn't know the detail of pulmonary denervation procedure. And anybody wants to say anything?
Well, I'm Googling what's pulmonary artery denervation is, and
Yes, I did the same. And I will share some information.
and then if this is a type of intervention, recent intervention, that will be concerning for something very, very, very rare that I don't think it. I have never seen it so far, like dissection.
Then let me give you a little bit information about the. So this was the full scan, but as I said, that was the only thing. That was the only finding. I don't know if I would be able to catch it, but the resident catch it. So this was a weekend call thing, and I'll share you. So the pulmonary denervation procedure, what they have been doing, they, as I said, I didn't know about the details of the procedure too. They started doing this. This first study is in 2013. What they are doing, this the pulmonary hypertension, not responsive to the medical management. What they are thinking, if they can denervate the sympathetic innervation over there, so they can give the patient a little bit better, outcome. That's what all these three study. One, the first one published in 2013, and then the follow-up 2022. They all completed. I didn't want to include all. They just said like exercise capacity improved, and all the findings get better. I don't know what they are doing. They're just going to the pulmonary artery, just like any kind of ablation. When they're doing, atrial fibrillation, they're ablating the symptomatic innervation in the pulmonary artery. So potential complications are they can create thrombus or pulmonary embolism. That thrombus can go to the distal vessel. They can create dissection, or they can even create perforation of the pulmonary arteries. And then lastly, since the phrenic nerve is passing really close that area, they can also create phrenic nerve paralysis. Those are the main complications. Although I'm mentioning them all, what they said in this three study, like complication rate was very, very low. So that's what they say. I don't know in your institute this is being done, or this is the first time that I saw. Just wanted to share with you. And in this case, we can argue. I was thinking more. The resident just said this is probably a small thrombus. I said this looks like a dissection. I don't know, what do you guys think? And I can show you the full CT. I try to zoom in to that area. That's the only finding here in this one. Can it be dissection?
Well, it's a little bit linear. Hard to tell if this is just a displaced small layer of the wall.
Focal internal tear.
Yeah, that's what I was gonna say. A pulmonary artery IT.
Looks like something like minimal aortic injury kind of thing, yeah? Like
That's what I was thinking. This is like probable minimal pulmonary injury, but still probable dissection. But as I said, we just mentioned and give them the differential diagnosis. This is the first time that I saw this procedure. I didn't know about it, and I wanted to share this case. I don't know the diagnosis, so whatever you say probably will be true, because I don't know the diagnosis. Okay, let me. So okay, the other complication in this case was honestly in this case. So this is pre-procedure CT, the same case, and this is post-procedure. So you can see the left diaphragm is elevated. So we just raised the concern like phrenic nerve paralysis might be possible. Just said it because looking at this is probably a couple of days before the surgery, and this is just right after the surgery. So definitely this diaphragm is elevated. So we just raised the concern. And as I said, these three studies said the complication rate is very low. But anyway, in this case, I guess they did some complication. This is my final case. And I didn't want to give choices here. I wanted to be a little bit tricky and a difficult question. A 55-year-old patient, recent in atrial ablation. What is the most likely diagnosis looking at the chest CT scan? This was a chest CT with contrast, I believe. And then we had some follow-up imaging. Anybody has? I know this is very difficult. But it was also very difficult to say abnormality when you're scrolling up and down this chest CT, because I think it's really subtle finding.
Is it related to pulmonary veins?
I'm so sorry.
I'm guessing it's an atrioesophageal fistula.
Very good. So I couldn't guess it. Yeah, that's definitely true. But you know how scary it is. At least for me, seeing this just gas bubble within the left atrium is your only chance to catch it on chest CT. This is your only chance to catch it. And when you're screwing up and down fast, you may miss it. And that's why I'm so scared of this. Whenever they're asking about atrioesophageal fistula. I'm so scared because the findings sometimes is very subtle. So this is a follow-up CT of heart. I can catch it at this time, of course, but not this time. I think this was difficult for me at least. So you can see the esophageal content is just getting through to the atrium, and unfortunately, this case had all the complications. So this patient initially presented with some neurologic deficit. That's why the patient started investigating, and the patient had splenic abscess. I'm just trying to raise the thing. Unfortunately, in this case on chest CT, they never give us any history of ablation or anything. Unfortunately, when you dig in, then you start understanding what's going on. But it is so important when you're thinking about atrioesophageal fistulization, especially ablation cases of maybe they did some esophageal procedure. It's sometimes the findings are very subtle. I have another case. Again, it's just a one gas bubble within the left atrium. You miss it, you miss the diagnosis, unfortunately, unless they are raising the concern clinically. So just a tricky case wanted to share with you. I don't know if anybody wants to add something. How can we increase our chance to catch this, especially if it is just a chest CT with contrast? I don't know that. Anybody wants to make any comment? Because I'm so scared of this atrioesophageal cases because I know that the findings are usually subtle and you have to be very careful for those. Anybody wants to make any comment about this case?
No, you're absolutely right. Like, you have to have a high degree of suspicion and scrutinize really closely, and almost overcall any stranding in that region, and say it can't be excluded even if you don't see like foci of error, just like, hey, there's stranding here, and given the patient's symptoms and recent procedural history, you can't exclude it.
Definitely right. There was another case that case I couldn't find it. It was a pericarditis case, and at that case it happened after this, and I was trying my best to try to see if there is any atrial fistulization. Look at it. It was a non-con scan, unfortunately. And as you just said, we said there's some loss of fat, stranding around it, so we cannot exclude. That case, we got CT of heart, and we proven it like that. Even though I was looking for it, and I still couldn't see it, but that was a non-con CT. Yeah.
Yeah, especially for how high of a mortality there is. I think it's like over 80% mortality.
And this patient recovered. This patient recovered and has some mild neurologic deficit. I followed up this case. This recovered and they drained the splenic abscess too. Yes, but they are really the other case that I said. The other one unfortunately passed away. They got the CT apart 4 hours later, and we proved it. But unfortunately, they couldn't do anything. In the morning, the patient passed away. Any other contribution? Well, that was my cases, and thank you so much for contributing and also like giving me opportunity to learn from you. And if there's any other feedback or any other comment, you can also email me. Thank you so much for listening to me.
Thank you, Dr. Prabhakar. So we still have little time. So those are really excellent cases, and I'm sure everybody had a good time with those cases. So I'll try to share my screen. I have a few cases. I'll go till um, 2 p.m. and whatever. You guys can see my screen.
Yes.
Okay.
Yes.
Yes. Thank
Yes, we
you.
can see it. Thank you.
So this is one case that I just signed this morning. So this patient presented with sepsis, scanned last night. So I have the CT here, and I know I went pretty quick. So I will go back again. So I feel like we are doing the similar team. We didn't discuss our cases. So, and this image, you saw an abnormality here. Like we are focusing on the cardiovascular chest.
Yeah, the aortic
Yeah.
valve leaflets are thick and lobulated.
Yeah, so aortic valve leaflet is thick and lobulated, and then the mitral valve area. So when we concentrate to the mitral valve area, it also doesn't look really good. And then,
In there too.
yeah, so we do not see that. And those things, my kind of resident could see those, but the one finding that I thought was relevant here when you are going down this area. So I'm going back and forth there. And then we see some hypoattenuation here. So this is not normal appearing paravalvular area. And then we have an associated hypoattenuation. So I'll go to the coronal here. So we have this area, which is not usually we do not see like that. Yeah. So in a patient with sepsis, we have
Maybe a small perivalvular abscess.
yes, yes, yes. So this person, yeah, that's what I wanted to discuss with you earlier, Ismail. I couldn't. Yeah, so this person had mitral vegetation and also aortic vegetation, and then there is this outpoaching of contrast, and then we see that hypoattenuation. So this outpoaching of contrast, we can label it as either pseudoaneurysm or um, abscess. Yeah, and when we see the hypoattenuation, we are pretty sure that there is an abscess. So we have this multiplanar here. So we see that outpoaching and some hypoattenuation. So that's my interpretation. So anybody want to comment and give some input here?
Can I ask one thing
Yeah.
about other experts' opinion? Do you call this like when it's infected, we can say abscess? What about not infected? Do we say pseudoaneurysm or aneurysm?
So to my understanding is that that when you have an outpoaching of contrast, that's a pseudoaneurysm. Is there an abscess or not? Whenever you see the hypoattenuated area associated, usually we say abscess. But if you do not see that and you do not know if the patient has infection or not, then probably I'd call it pseudoaneurysm. What do you guys think? We have many other experts here, so.
No, I agree. I think it's a spectrum of the same process.
Yes, yes, yes. And why it would happen? Yeah, so most like there should be a reason why it is happening, and most of the time that reason is infection, and so you will often see an abscess. So like when a patient has a valve prosthesis, in long term you see the pseudoaneurysm, you may not even see the hypoattenuated area, still you will consider it an abscess because you know like what else could happen uh, to cause that, unless trauma may be penetrating or non-penetrating. Yeah. Any other comment?
Why not like underlying disjunction?
What is that? Sorry.
Like a mitral annular disjunction can have this appearance.
Yes, so mitral annular disjunction can have that appearance. That's a very good thought. But in those cases, so if we go back, you can see that your annulus is properly kind of, I do not have a three chamber, of course, like that would have been better. So you see that area out there, so and you are losing that, yeah. So in mitral annular disjunction, your annulus should be complete. It should not, you should not lose that, yeah. And what you will see that this muscular part will be away from the annulus, and this part, this is outpoaching. This is not like that. This muscular part is coming to the annulus. So if you have a gap between the annulus and the muscular part, then we think about mitral annular disjunction. Sorry. Okay, so if you guys agree, then I did correctly report it. Thank you.
There's a question how to differentiate from MAC. I guess we can use non-con to see if
Yes.
there's any calcification.
Yes, yes. So we'll have to use non-con to differentiate caseous necrosis of mitral annular calcification. Yep. Mhm. Yeah. And in this case, there was no calcification. Okay, so I have put this T2 T2 Scout. Dr. Kavakus already talked about it. So this is a normal T2 Scout. Yeah. So Dr. Kavakus already said it. So I'll quickly go through it unless somebody has any comment. So the blood nulls before the myocardium, and when you have that opposite, the blood nulls after the myocardium, then you think about infiltrating disease. And when you have infiltrating disease with this physiology, what is the
Amyloidosis,
physiology here?
infiltrative disease like amyloidosis.
Yeah, but what kind of physiology we have?
Restrictive physiology.
Restrictive physiology. Yeah, so you are correct. So this is amyloidosis. The left ventricle and right ventricle are not filling properly, so not appropriate preload, and that is the problem. So restrictive cardiomyopathy, and you see enhancement like that. This is amyloid. So I'll go quick, so you all know it. This is a 66-year-old male with chest pain, and this is. I'll go slow here. So this is the stress perfusion. Okay. So I'll keep the stress perfusion here, and you see the extent, and this is the rest perfusion. So how do you want to comment?
Did you say peri-infarct ischemia?
Perfusion defect in rest and the larger one in the stress images.
Yeah, so do you want to ask me
Peri-infarct ischemia.
yeah, so do you want to ask me a question like which one was done before? Like stress or rest? Does it have any significance? Because this is the MRI, we are doing it at the same time, yeah? So we are doing either stress first or we are doing rest first. And so
Usually stress first.
usually stress first. So we did the stress first, and then we did the rest. So it seems like there is a kind of infarct with some surrounding ischemia. But is that true? Like here we have the uh, we have the we have the like the extent that we are thinking, is that the true extent of ischemia, or is it less than that? So we have the SSFP here where myocardium is already enhancing because we did the stress before our short axis SSFP. And then you look at the delayed enhancement, there is a large area of delayed enhancement that is not showing resting perfusion defect because that area is already enhancing. So that is the problem with cardiac MRI stress and rest comparison. So I'd like to compare the stress with my delayed enhancement images, because delayed enhancement enhancing areas are like, if it is not really acute infarct, I will also look at the T2, then most of the time those areas will be scar, and then this will be peri-infarct ischemia. You guys agree or not? So you agree that there will be some enhancement on the resting perfusion that can uh, limit visualization of hypoattenuated area?
Yeah, we agree. I agree.
Uh,
But
uh,
it's a bit confusing. That's why in our center, I'm working in Southampton, UK.
uh,
We are not doing wrist perfusion.
yeah, that's such a good point. So many centers actually
It's wrist,
stop doing resting perfusion,
yeah.
any kind of cardiac scan, because most of the time it doesn't help. You look at the delayed enhancement, and most of the time you can save a lot of time if you inject the patient outside and then scan the patient. Yeah. So yeah, how do you do it, Mohammed, like in your place?
Just like stress, only stress. We are not doing wrist perfusion anymore.
Okay, so you compare the stress and with the delayed enhancement like here. Yeah. And
Any stress and late enhancement.
yeah, so like I put it here. So you see the extent of delayed enhancement, then we have a little bit of microvascular obstruction that Dr. Kavakos taught us today. And then you can debate how much of peri-infarct ischemia, but the point here is that you cannot always go with rest if you're doing the rest after the stress, because there may be some contrast enhancement. Okay.
Yeah.
So I have little time. So this was an acute myocardial infarction patient. So we know acute myocardial infarction diagnosis. So we have this sort axial images. So I start here, go, 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 and then we started that one. I can go slow, so I'll go slow from here. Anybody? So this is a known ischemia, acute myocardial infarction.
Septal perforation, MI related?
Yeah, so one thing that we see is hypoattenuation. Yeah, so there is definitely some hypoattenuation. I know it may not be projecting very well. You might want to window it, but believe me, there is hypoattenuation. And then this out in the inferior wall. Yeah, so go ahead, Noha. Somebody was saying something. Sorry, go ahead.
I said the true aneurysm.
So this is. So do you think this aneurysm is related to the infarct, acute infarct? And see how it is bulging, so and involving the inferior wall. So this is probably because of the rupture of the infarct. Okay, so this location is common for rupture, and you see how the neck is and how it is bulging out. So this is probably a pseudoaneurysm related to the infarct. Probably it ruptured and causes the aneurysm. So we have the coronal here. You can see that here. And there is connection, as Dr. Kabako said, between the atrium and ventricle. This patient also has a known VSD from before. So that is the known VSD connection in the apical area. But in the base to mid or in the mid area, there is that inferior wall rupture with pseudoaneurysm. So this is the common location for acute MI-related ventricular rupture and aneurysm. You do not see the anterior wall or apical. Probably those patients usually die, and those cases you see actually true aneurysm in those areas. So this was the aneurysm. See how it is going out. It is not like the wall bulging out. I'll show you an example. It is like something ruptured and contained. And then we give the measurement out there. So this person has that connection in the apex, that is the known VSD. And then you have this rupture out here. See how it is going out? So this is how the true aneurysms, they do not go out like that. And then location is something that we give real importance. So, and usually true aneurysm looks like that. Yeah. So this has some thrombus associated. So that I thought that was an interesting case of rupture of the inferior wall due to probably RC acute infarct. Any other comment, or somebody do not agree? I'd like to hear about.
Yes, I agree. The previous one is pseudoaneurysm with narrow neck. Yes.
Yes, yes. So it ruptured and the blood goes out and somehow contained. Yeah. And in this case, you have the wall, which is thinned, and then this is true aneurysm. Okay. Thank you. So I have time for one more. So left atrial appendage occlusion. I think you guys are doing a lot probably. So this is a patient with left atrial appendage occlusion post follow-up. So you can see the device on your X-ray. So this, I will not name the vendors. So this has some part. So this is a lobe. So that is nitinol. And then you have a disc proximally, which they claim that closes the appendage properly and also prevents device-associated thrombus, and then has a waist here that helps to accommodate different kind of appendages. So these patients, when we looked at, so I'll probably go quickly because you guys already do these kind of things. So, and I just wanted to know whether you do something different. So there is some leak associated with this device. And on the arterial phase, we see some non-opacification. But then when you do the venous phase, the delayed phase, we do 1 minute delay. So if you guys do it differently, please let me know. So on the delayed, we see there is filling of that left atrial appendage. As because this is 1 year after, so more than 6 months after, we call it a peri-device leak, and we see the leak. And when we see a leak like that, usually we give measurement like that. So the diameter, the area of the leak. So this is a peri-device leak and persistent opacification. So you guys agree or want to have any comment?
Yes,
Okay.
agree.
Yeah, I think this is pretty standard. So the one follow-up on this, so this patient is the device is appropriately positioned, so there is no peri-device leak, and but there is opacification distal to the left the device in the left atrial appendage, and there is a little bit of hypoattenuation towards the atrial side of the device. So now what do we do? What do you think going on here? We didn't see a leak. What are the possibilities? Anybody? Okay, so because of interest of time, I'll go with it. So because when they put these devices, it takes time to endothelialize and obliterate the left atrial appendage. So that time, what we agreed and different publication and last time when we discussed at NASCI was 45 days to 6 months. So if the patient is within 6 months, then you can term it as incomplete device endothelialization. And when it is more than 6 months, so suppose 1 year, then you can say that there is opacification with inconclusive peri-device leak. So you do not see a device leak, but it is inconclusive. There may be one that you do not see. So those are the terms. So it may be inconclusive peri-device leak, or it may be incomplete endothelialization. So then what do you do with this hypoattenuated thickening? Yeah. So is it just hypoattenuated thickening or thrombus? So what is agreed upon is that if it is less than 3 millimeter, you call it hypoattenuated thickening. If it is more than 3 millimeter, you call it thrombus. So that's what we practice. So anybody want to give any comment here? Okay, so I think probably you guys agree or don't want to correct me. So thank you. So I will quickly, so one more and then we go. So this is a quick, real quick. So you will have to be real expert to do this. So this person has pneumothorax. There is a tube here and look at the tube and you will know why I'm saying that you will have to be a real expert to do this.
Wow.
so so you see that you see the tube in the heart and luckily they didn't take it out, so they took the patient to surgery and took it out and closed it, and it's a very young patient and the patient survived. Yeah,
And
I think
I read this CT.
you read the city.
In
Yeah,
the morning, I read this.
yeah, so I think
So just
this.
maybe when they inserted it, it drained some bright blood or something. That's why they were afraid to take it out. That's
Yes, yes, I
Yes, they
think.
know it. They know they cannulated either a great artery, something. They know it, so they were really scared. The thing is, they try to do an anterior approach because pneumothorax it was there, I guess. So they
uh,
inserted it into the left ventricle. Yeah.
yeah,
yeah. So
very
they came anteriorly. Yeah, you are right, Ismail. So they came anteriorly and put this in the left ventricle. So this is big. So
Thank
yeah,
you for sharing.
yeah. I think we could probably able to have some engaging discussion. And thank you for your input. I know these things are very routine for you guys. Probably you do all regularly, but we wanted to just have some discussion, keep learning from each other. And thank you for joining. Really appreciate it.
Thank you
Thank
very
you
much.
all so much.
Thank
Thank you,
you.
Jonathan. Yep. See you guys later. Bye.